Hey all, welcome back to the Real Life Pharmacology Podcast. I am your host, Pharmacist Eric Christensen. Thank you so much for listening today. As always, go check out the free 31-page PDF on the top 200 drugs. Great study guide, great refresher, lots of things on there that'll show up on board exams as well as in clinical practice. So simply an email will get you access to that. Absolutely a no-brainer to go ahead and get that at reallifepharmacology.com. All right, so we are going to be talking antiarrhythmics today. This is, generally considered a class of higher risk medications. Keep in mind, there's some different classes and some different agents, and we've got things like beta blockers and calcium channel blockers, which maybe aren't classified as more higher risk medications, but many of the others within this class of drug are considered a little bit more high risk. Some other things that I just wanted to kind of give you a general outline on, a review, if you will. Narrow therapeutic index medications, so a lot of antiarrhythmics, or some of them certainly, have this concern. So basically what that means is it's a tight window between a toxic concentration and a subtherapeutic concentration. So sometimes it can be difficult to get the dosing just right to where we effectively treat the condition, the arrhythmia, if you will, but also avoid toxicity. So that's harder to do when we've got a narrow therapeutic index medication. And also, whenever you have a narrow therapeutic index medication, you're often going to be checking lab work to make sure that that medication stays within the target concentration that we're trying to do. So, again, many antiarrhythmics do fall within this window. The classic examples that show up on board exams and you may see out in practice are 1, amiodarone, and 2, digoxin. Those are by far, in my opinion, the ones that you're probably going to see the most. Digoxin, I would say, over the years we've seen a little bit less of that. Used to be used in heart failure as well as atrial fibrillation. I see a little bit less of it than I have seen in previous years, but definitely an important one to remember. Many of the antiarrhythmics are also proarrhythmic medications, so they can be used to treat arrhythmias, but they can also cause new arrhythmias. So obviously, monitoring that medication is really, really important. One of the most feared complications is torsades de pointes, which is typically a result of QT prolongation or QTC prolongation. Okay, so in monitoring medications, that's one of the most important things that I look out for with the use of antiarrhythmics in general is that QT prolongation. And the reason for that is many medications can increase the risk for QT prolongation, and that's a drug interaction concern that we typically have. One other thing that I pay attention to is electrolytes. So things like potassium and magnesium play an important role, and if those electrolytes are off, if we're significantly low, for example, on potassium, that can increase the risk for arrhythmias and complications with many of these antiarrhythmic agents. All right, so let's get into the classification system a little bit. The Vaughan Williams classification, we've got 4 classes, and probably the easiest way I remember it is 2 and 4 are more common medications. So class 2 is beta blockers, and class 4 is calcium channel blockers. So beta blockers being metoprolol, propranolol, and so on and so forth. Calcium channel blockers being medications like diltiazem and verapamil. Remember that calcium channel blockers like amlodipine, so the dihydropyridine calcium channel blockers, those don't have the effects on the heart that diltiazem and verapamil do. So if you remember, even those are the more commonly used agents in practice, probably oftentimes for other indications. And if you remember the odd numbers, class 1 and class 3, these are generally more medications that are strictly used just for arrhythmias. So class 1 are the sodium channel blockers, and we do have subclasses here. In general, it's not something I've been tested on very much, but I'll put it in here for reference. So like 1A, that's like quinidine, procainamide. 1B is lidocaine. 1C is flecainide and propafenone. So those are some examples of each one there. Again, class 2 agents, beta blockers, metoprolol, atenolol, propranolol, so on and so forth. They block that sympathetic stimulation of the heart and ultimately slow the heart rate down. The most common, or one of the most common heart arrhythmias is atrial fibrillation. And beta blockers, in my experience, are most often used as a first-line agent in rate control, basically slowing down that heart rate in atrial fibrillation. Also remember, there's plenty of alternative indications or compelling indications, I guess, if you will, with beta blockers. Anything from migraines to, post-MI, things like that. So pay attention to that. We may have a dual purpose to use a beta blocker in a situation like that. Class 3 is considered the potassium channel blockers. Amiodarone is typically considered to be within this class. Amiodarone can have kind of a few different mechanisms a little bit, but amiodarone probably falls most appropriately in class 3. Dofetilide is another example here, and dronedarone as well, so kind of a little bit of a cousin to amiodarone. For the use of antiarrhythmics, amiodarone is the one that I see most commonly used in practice on a chronic basis. One of the biggest things to remember with this class in general, but probably specifically to amiodarone, just because it's used so often, is that QT prolongation risk. And then we've got the class 4 antiarrhythmics, diltiazem, verapamil. These are the calcium channel blockers. So again, these slow down the heart rate, and I've covered those medications plenty in previous podcast episodes. So just go ahead and search them up at reallifepharmacology.com if you want a lot more details on those. All right, let's talk quick about torsades points. So associated with QT prolongation, what I'm looking out for with this is obviously any drugs that are added to a patient's medication list that can prolong the QT interval. Many antipsychotics, there's quite a few antibiotics, quinolone antibiotics, for example. Some of the macrolide antibiotics may be associated with it as well. There are many, many medications that can cause or contribute to QT prolongation. So if you're not sure, if you think a patient's at risk, that is definitely something important to look up for sure. All right, one other thing with QT prolongation, I do want to mention diuretics. So again, potassium, magnesium, super important to pay attention to that, monitor that. If we get low there's a greater risk that we're going to induce arrhythmia in a patient taking amiodarone, for example. So making sure those electrolytes remain within normal limits, super, super important there. All right, let's take a quick break from our sponsor, and we'll wrap up with amiodarone and other medications. If you're in the market for any pharmacist board certification study material like BCPS, ambulatory care, geriatrics, BCMTMS, NAPLEX, go check out meded101.com/store. We've helped thousands of pharmacists prepare and pass their exam. We can absolutely help you too. So again, support the sponsor, meded101.com/store. In addition, if you're a nurse, pharmacy technician, other healthcare professional, we've got other resources too. We've got review courses, we've got books on Amazon, tons of different options and opportunities to help support this podcast. So again, all those links, meded101.com/store. All right, so I wanted to cover amiodarone a little bit more specifically. I have done a podcast in full on this medication, so if you want to go listen to that, you certainly can. Just search it up at reallifepharmacology.com. But some important test prep pearls, if you will, as well as things that are important in practice too. So extremely long half-life. We're talking days to weeks, approximately in the neighborhood of 40 to 60 days. So just because you stop the amiodarone doesn't mean the concentrations are going to go to nothing within 24 hours, okay? So very, very long half-life. Takes a while to get that amiodarone out of the system. Important toxicities to remember. So one is pulmonary toxicity. Super, super important. I've seen cases where this has happened. Many times clinicians will overlook the amiodarone or not pay attention to it, and assume a patient has COPD or another respiratory disease, and typically start our usual respiratory medications. Your beta agonists, your anticholinergic medications to treat some of those respiratory symptoms. Not recognizing that pulmonary toxicity may be due to amiodarone. So if you ever see, a worsening of respiratory symptoms in a patient, we're needing new medications to manage those respiratory symptoms, definitely go back through, look at that medication list and make sure that they aren't taking amiodarone, which can cause pulmonary toxicity. The next one, thyroid dysfunction. I have caught numerous hypothyroidism cases, definitely more than I can count on my hand over my career, where I've simply asked to check a TSH in a patient taking amiodarone on a chronic basis. So really got to pay attention to that. Make sure that we're monitoring thyroid function with the use of chronic amiodarone. And then liver toxicity is the other big one that will frequently show up on board exams and also important in practice as well. So we're going to want to monitor liver function tests, thyroid function, and then we may do some chest imaging and things like that as well if we're concerned about the risk for pulmonary toxicity. Amiodarane's got plenty of drug interactions as well. Classic ones being warfarin, so definitely pay attention to that. Digoxin's another one that significantly interacts with amiodarone, and statins as well. Particularly simvastatin has a dosing limitation with the use or in combination with the use of amiodarone. All right, as we wrap up the podcast, I do want to talk a little bit about QT prolongation. With that, I often get asked by students, like, what do we do, in the situation of QT prolongation? Let's say, we've got a patient taking amiodarone and, provider wants to start an antibiotic or an antipsychotic or another medication that could prolong the QT interval. So first off, the thing I probably think about most is kind of that threshold of, what's concerning and those type of things. So Most patients in my experience, normal, they're going to run 420 to 450. Again, I work mostly in geriatrics and that type of thing. May vary a little bit from that. Typically, where I'm starting to get maybe a little bit more concerned is in that, 470 to 480 range. And I would say seriously concerning is above 500 milliseconds for that QTC interval. Okay. So that's kind of the cutoff of, okay, we should be, maybe working with cardiology, figuring out what to do, reducing, medication burden that causes that QTC prolongation. So those are some really, really important things to think about. And again, I go back to the electrolyte monitoring as well, making sure those all look normal and okay too. With that said, I wanted to remind you about a resource that I had somebody share with me. We've got QT prolongation for community pharmacists quick guide. So if you Google search that at meded101.com, had a really nice article put together by a pharmacist that helped me do it. It's a few years old now, but it's got a lot of great principles on it regarding QT prolongation and just the mindset and paying attention to it and all that sort of stuff. So definitely wanted to highlight that a little bit in our discussion of antiarrhythmics, recognizing that this can be a significant issue for sure. And again, go search the podcast. I've done hundreds of episodes on individual medications. So if there's a med specifically you want to look at, go back into the podcast archives. Go check that out. Look for the specific drug that you're looking for more info. If I don't have anything out there, feel free to drop me an email, mededucation101@gmail.com. Always looking for new ideas, suggestions, all that sort of stuff. Of course, support the sponsor, meded101.com. Get your free 31-page PDF at reallifepharmacology.com. Great little study guide on the top 200 medications. And as always, if you enjoyed this podcast episode, do me a huge favor. Leave a rating and review on iTunes or wherever you're listening. And also share us, friends, colleagues, healthcare students, anyone who could benefit from some pharmacology education. All right, well, that wraps up the episode for today. Thank you so much for listening. Please don't hesitate to reach out, mededucation101@gmail.com if you got questions or comments. And I hope you take care. Have a great rest of your day.